Coming to the pathology of the respiratory tract. The respiratory tract pathology can be broadly understood under three categories: the infective, the inflammatory, and the neoplastic. Infective, as is understood, is by an infective organism. It can be a bacteria, it can be a virus, it can be fungal, or it can be parasitic. Inflammatory pathology affecting the lungs is mostly a chronic inflammation or due to a structural alteration in the respiratory tract, structural alteration in the form of remodification of the smooth muscle cells, as we see in bronchial asthma, destruction of the bronchi or the bronchioles, as we see in emphysema, causing inflammatory or structural pathology. Now, neoplastic pathology can be benign, which is rare, and malignant, which is most common. And this is commonly associated with the air pollutants and the lifestyle habits such as smoking. Infectious pathology is broadly classified into bronchitis, bronchiolitis, lung abscess, and the most common, pneumonia. Pneumonia, we have heard it often. Pneumonia means inflammation of lung parenchyma. Now, pneumonia can be divided further in basing on which part of the lung is affected into three subcategories. You have lobar pneumonia, you have bronchopneumonia, and we have interstitial pneumonia. Lobar pneumonia affects a lobe, a part of a lobe, both or three lobes. Bronchopneumonia, as the name suggests, involves the part of the lung around a bronchus. And interstitial pneumonia happens to affect the interstitium between the alveolar septae. Pneumonia happens because of various infective etiological factors. It could be bacteria, it could be virus, it could be fungal. Most commonly, pneumonia is caused by viral agents. Based on the clinical setting of how pneumonia is acquired, you can acquire it from community. It's called community acquired pneumonia. It can be acquired in a hospital setup when it is called or hospital acquired pneumonia. And thirdly, ventilator associated pneumonia. Pneumonia is caused by a direct inhalation of the etiological agent, the classic example being COVID-19 and H1N1, that is swine flu, or aspiration of the organisms, that is taking in or accidental inhalation of the food particles or organisms into the lungs, direct spread from an adjoining infective site, and fourthly, hematogenous spread from a distant site. Failure of defense mechanisms and presence of certain predisposing factors cause pneumonia. These predisposing factors can be altered sensorium, as seen in alcoholics, drug abusers, patients with head trauma and head surgeries, impaired ciliary motility syndrome, impaired alveolar macrophage activity, as seen in cigarette smoking, inhalation of pollutants or corrosive gases, depressed cough reflex, as seen in patients who have undergone head surgeries, that is brain surgeries, people on ventilator, again alcoholics, drug abusers, people who have undergone tracheostomy, then presence of endobronchial obstruction, either because of presence of tumor or presence of a foreign body. Lastly, immunocompromised states or immunosuppressed states, as we see in acquired immunodeficiency syndromes or patients suffering with cancer who are put on immunosuppressives. Let's learn about the pathophysiology of lobar pneumonia. Lobar pneumonia is caused by the organism most commonly by Streptococcus pneumoniae. And clinically and pathologically, it's divided into 4 stages in a sequential order. Unfortunately or fortunately, we don't get to see all the 4 stages in the same order of sequence anymore because of the early institution of antibacterial therapy these days. The order of events or the sequence of events as we see in lobar pneumonia are the stage of congestion, or it is the initial phase, stage of red hepatization, early consolidation is the other name given to it, stage of grey hepatization or late consolidation, and stage of resolution. Now let's divide them into these 4 parts and try to understand what these clinical and pathological sequences are. Coming to the first Congestion, as we can understand, has engorgement of vessels, and these vessels are filled with RBCs, and this engorged vessels make the lung very boggy and heavy and giving it a slightly flushed or congested appearance, that is red in color. At this stage, we don't have any infiltration by inflammatory cells, that is neutrophils is what we expect in pneumonia. The second stage, that is the early consolidation phase or the red hepatization phase, is the phase where you have the influx of neutrophils through the leaky vessels. The congested vessels that we see in the first stage are becoming leaky because of the inflammatory cytokines that are released. These leaky vessels allow the passage of the protective WBCs, that is the neutrophils, which form the first line of defense. And these WBCs, that is neutrophils, enter the alveolar spaces, and because the vessels are leaky, you have the fluid, that is the proteinaceous fluid, coming along with them. So in early consolidation or the red hepatization phase, we have the alveoli filled with fluid, filled with red blood cells and with neutrophils. Now at this stage, because it appears very firm to touch and it is heavy and it is not as boggy as in consolidation, it has a very liver-like look, and hence the name red hepatization. As you all know, hepatization or hepatic refers to liver. Coming to the third stage. The second stage usually starts around the second to third day. The third stage starts around fourth day and can progress to any number of days, usually limited to 1 week, right? So the third stage is called grey hepatization or late consolidation. Now what happens in late consolidation? Here the neutrophils which have accumulated in the alveoli start degenerating because they have done their function, and RBCs too, they start degenerating or breaking down. So what happens when the RBCs break down? You have hemosiderin forming, right? And the neutrophils, they break down into pus-like material. So it is basically degenerated neutrophils and RBCs that are seen in the grey hepatization phase. It is called grey hepatization phase because the RBCs lose their red color, right? They have degenerated, so they don't appear red anymore. In fact, they appear little brownish or copperish, right? So this grey hepatization phase is characterized by mostly degeneration. Now this is followed by resolution. In resolution, all this degenerated material is carried away or taken away to be metabolized by the local macrophages. These are histiocytes which are trained, or which are main function is to take away and engulf any degenerated material. So here we have degenerated RBCs and neutrophils which are digested by the macrophages. So in this stage, that is the stage of resolution, you have the alveoli filled with alveolar macrophages. These are the resident macrophages of the alveoli, and these macrophages engulf the degenerated neutrophils and RBCs, and there may be, in some case, depending on how severe the pneumonia is, you can have fibrosis forming too. Coming to the pathophysiology of interstitial pneumonia. Interstitial pneumonia, unlike lobar pneumonia, is caused by most commonly viral organisms, mycoplasma and chlamydia. Here the action or the inflammatory process is limited to the interstitial tissue, that is the tissue present between the alveolar sacs. So we don't expect any neutrophils in the alveolar sacs, and if at all, you can just find inflammatory fluid or exudative fluid in the alveolar sacs. The interstitial septae or interstitial tissue between the alveolar sacs is where all the inflammation takes place, and it is filled with mononuclear infiltrate. Because it is viral infection, the most common inflammatory cells involved are macrophages, lymphocytes and plasma cells. So you have mononuclear infiltrate in the interstitial septae and no inflammatory cells in the alveolar sacs. At the most, you can find exudative fluid in the alveolar sacs. Coming to the pathophysiology of bronchopneumonia. Bronchopneumonia can be caused either by bacteria or virus. Bronchopneumonia is a patchy consolidation of the lung, and this patchy consolidation usually can affect one lobe or more than one lobe. It is usually bilateral and involves the lower zones because of the gravitational collection of these secretions. Now, grossly, areas of the lung which is involved by bronchopneumonia can be made out by their red to grey look, that is the red to grey hepatized look. And these areas, these patchy areas in the lung are usually centered around either bronchus or a bronchiole. So you have peribronchular grey and red hepatized areas in the lung, and these are patchy, and these areas are usually around 3 to 4 centimeters in diameter. They have a rough, dry, granular appearance on cut surface, and this is the gross appearance, that is the physical appearance, not under microscopy. Under microscopy, because it is involvement of the tissue around a bronchus or a bronchiole, you will have features of both lobar pneumonia and interstitial pneumonia. So what are the features of lobar and interstitial pneumonia? In lobar pneumonia, you have collection of the inflammatory cells within the alveolar sacs, and in interstitial pneumonia, it is the interstitial septae that are involved. So both of these features are present in bronchopneumonia. These are the pathophysiological features of lobar, interstitial and bronchopneumonia. Now, because it's an acute inflammatory response, clinically the patients present with high grade fever, right? It is high grade fever, cough and a rusty sputum. The rusty sputum can be explained by the presence of the RBC in the alveolar sacs. Coming to the lab diagnosis of pneumonia. Pneumonia is predominantly a clinical diagnosis, but you have other laboratory investigations that aid in the diagnosis of pneumonia, such as X-rays, blood tests, sputum culture and examination, and culture sensitivity and examination of BAL fluid. What does BAL stand for? BAL stands for bronchoalveolar lavage. Bronchoalveolar lavage fluid is sent for culture sensitivity, special stains in microbiology, and these days it is specially sent for PCR examination or PCR testing, wherein specific bacteria or viri can be identified.